Hello, everyone, and welcome. Want to give everybody an opportunity to get in, get situated, have a seat, et cetera, and then we'll get started. So welcome we appreciate you joining us. I'm excited to have Dr. Cornia talk about chronic kidney disease, major issue in cats. So let me do some housekeeping first. At the end of the webinar will be information on how to get your CE certificates. So you want to stick around for that. And I do want to, let me go ahead and introduce Dr. Cornia and then a couple other little housekeeping. Please put your questions in the Q&A feature and we'll answer those at the end of the webinar. And then also, I want to make sure that everybody knows Every Cat Health Foundation is a nonprofit. So if you appreciate the education information that you get from us, the research that we funded, I will be putting into the chat feature a link for you to make a donation if you would like. So let me start by introducing Dr. Cornia. Go ahead to the next one. Dr. Cornia is an international medicine specialist. Excuse me. He is international medicine specialist and criticalist who graduated from the Ontario Veterinary College in 2014 and initially entered private practice. He spent 6 years in feline specialty practice and then completed an ABVP, American Board of Veterinary Practitioners, feline specialty in feline residency in 2019. During that time, he also worked as an emergency veterinarian. He completed a small animal internal medicine program and DVSC at the Ontario Veterinary College in 2023, and now serves as an associate faculty while enrolled in a critical care residency. So can you say overachiever? He's the author of numerous scientific papers, textbook chapters, and articles for cat owners. He serves on the Every Cat Health Foundation Scientific Review Committee and the Education Committee, and he writes summaries for our Every Cat Health research library as well. He's involved in the Feline VMA, formerly the American Association of Feline Practitioners, the ICVA, and other veterinary education organizations. And we are so excited he joined the board of Every Cat Health Foundation in 2024. Dr. Cornia lives in Guelph, Ontario with, count them, 7 cats. One more thing I want to do before we start is I do want to say thank you to our sponsors for this. Thank you very much to the Viticus Group, Viticus Animal Health, the sponsors of the Western Veterinary Conference. Thank you very much to them for sponsoring this webinar. Dr. Matt, go.
Hey there, thanks a lot. Just getting my screen right. There we go. Perfect. So we're here today to talk about chronic kidney disease, especially in the context of renal biomarkers and some of the kind of diagnostic tests we have for this condition. So just as a quick review, chronic kidney disease, as we know, is one of the most common conditions of geriatric cats. It affects about 30% of cats over the age of 10 and up to 80% of cats over the age of 15. It is a progressive degenerative disease characterized by a loss of kidney function over time. It's something that we can manage, but is not a curable issue. And while the cause is not fully understood, we think that it is either a combination of multiple insults to the kidneys building up over time, a slow progressive loss of function, or possibly a combination of the two. When we think about the physiology of CKD, we think about a loss of nephrons, the individual structures that make up the functional units of the kidney. Cats have around 400,000 of these at birth, about 200,000 per kidney, and chronic kidney disease involves a gradual death of these nephrons. This is through inflammation, through blood clots, and through inflammation of them with fibrous or scar tissue. And importantly, in cats, the tubular components of the kidneys are affected more than the glomeruli, which differentiates it from some of the conditions that we'll see in dogs. So what are the symptoms we'll see of chronic kidney disease? Well, increased drinking and urinating, loss of appetite, weight loss, especially loss of muscle mass. We'll see that kind of boniness and stegosaurus effect over the spine. Lethargy, anemia, electrolyte changes, especially low potassium values. Hypertension, which we obviously don't see clinically, but we might see manifest as strokes or retinal detachments, and of course, eventually death. Importantly, not all cats will have all of these symptoms, and some cats can have different ones and different combinations, and they don't necessarily happen in a predictable order either, which can make trending these guys on clinical signs very difficult. How do we manage CKD? Again, this could be a whole lecture series by itself, but in general, we're looking at dietary therapy, moderate protein, low phosphorus, high omega-3s. We're looking at things like phosphate binders, maintenance of hydration with fluid therapy. We're looking at appetite stimulants and anti-nauseants, sometimes erythropoietic agents to get more red cells into them, medications to treat high blood pressure and protein in the urine, and a whole host of other things. Again, the purpose of this lecture isn't to really go over the treatment of CKD, but just to reinforce that once we've made this diagnosis, there are a lot of things that we can do, a lot of ways that we can try to trend the progression of this condition and manage what we're seeing going forward. So that leads us to that obvious question of, okay, how do we diagnose chronic kidney disease? Well, the classic criteria, and still a very good way to make a diagnosis, is that combination of elevated urea and creatinine in combination with a low urine-specific gravity. And that second part is important to remember. I regularly see people, kind of making these diagnoses just on the urea and creatinine values and realizing that pairing them with that specific gravity is really essential to differentiate pre-renal from renal causes of azotemia. Importantly, this indicates a loss of kidney function, but as we're going to talk about, is actually one of the later changes that we see in the progression of chronic kidney disease. What are some supportive criteria? Well, things like small kidneys you might see on palpation or radiographs, and certainly the clinical signs we talked about in the last slide are all things that might back up that diagnosis, but I'm never going to make a diagnosis of kidney disease just based on those. So what are some of the challenges we see in making this diagnosis? Well, the big thing is that the kidneys have an extensive functional reserve. Markers of kidney function are not changed early in disease. And this kind of makes sense. We all know that we can donate a kidney and do just fine. And well, that means that if we donate a kidney, we cut our nephron number in half and still have no clinical signs of disease. And we really need to see somewhere in the 70% loss of function to see significant changes on blood work. The same is true with clinical signs. They're not present until the disease is advanced. And at that point, intervention is going to be harder, and it may not even be possible to intervene once we're in this advanced stage of disease. What does this mean? Well, it means that early and accurate biomarkers are necessary for these CKD cats. So what is a biomarker? Well, a biomarker is any biological property that can be measured to indicate the risk or progression of a disease or how a patient can respond to treatment. I know that's not a very specific term, but that's because biomarkers are not really a specific thing. Basically, anything you can measure in a patient that is indicative of disease is a biomarker. This could be a blood test or a urine test. It could be a diagnostic imaging finding, or it could even be a finding on physical exam. So what are the characteristics we think about in an ideal biomarker? Well, our ideal marker should be consistent. If we run it multiple times in the same animal, we should get the same result. It should be patient-friendly. I don't want to have to anesthetize and get a kidney biopsy just to make a diagnosis. It should be practical. We should be able to do it reasonably without undue cost or effort or kind of stress on the patient and practitioner. It should be quantitative. I'd like to get a number and not just a positive or negative, but something that I can use to trend. Obviously, it should be reliable and valid. I should be able to trust the result that I have is actually a marker of the disease that I have. Obviously, it should be sensitive and specific. I want to be able to pick up all the cases of disease, and I don't want to pick up any false positives. It should be safe. If we're going to kill the patient getting a diagnosis, obviously that's not very helpful. And it should be inexpensive. Everyone should be able to afford it. And so I want to be able to look at all of these factors when I'm picking my ideal biomarker to diagnose a condition. So when it comes to kidney disease, what is our ideal biomarker? Unfortunately, it doesn't exist. We have nothing that fulfills even half of these criteria, never mind all of them. That means we need to make do with non-ideal markers. And we'll often use these in combination and say, well, if I don't have one perfect marker, maybe if I put these 5 together, I can come up with something that works okay for me. When we think about our biomarkers, we can group them into 3 big categories, which is how I'm going to talk about these going forward. In the kidney, we think about functional markers, we think about damage or injury markers, and we think about the other biomarkers that I couldn't fit into one of these categories. The functional markers of CKD are values that correlate with the function of the kidneys. They will increase or decrease in value along with the severity of disease. These are obviously useful to determine the stage of disease and prognosticate how the animal is going to do. Ultimately, our functional biomarkers are surrogates for the glomerular filtration rate, or GFR. The GFR is the rate at which the blood is filtered by the kidneys. It is your primary marker of kidney function. And as we mentioned, basically every functional biomarker is us trying to find a cheap, easy, non-invasive way to measure GFR. GFR is influenced by a lot of things. Obviously, the amount of kidney function we have, how much functional tissue, is one of the big influences, and the one I care the most about. But it's also influenced by the blood flow in and within the kidneys, blood pressure, hydration status, urinary obstruction, and a host of other factors that can contribute to it. Actually measuring GFR is difficult, and there is no perfect test for it in veterinary or really in human medicine. We can do blood tests for GFR, but they're frankly a pain. It usually involves injecting some kind of medication and then taking several blood tests over the course of hours to see how that level changes in the blood or urine. Doable, but gosh, not something we want to do as an early screening test in all the cats that walk into the clinic. We could also do imaging-based methods, things like scintigraphy, which we see here, or CT scans. These are useful, but again, they're expensive and not widely available. And so what do we rely on? Well, our creatinine, urea, and SDMA, which are all surrogates for glomerular filtration rate. As an aside, I want to mention that if you have blood work done as a person, you will most likely see an eGFR pop out. That's an estimated GFR. And that's basically a calculated value where they have taken your creatinine, age, sex, race, body weight, a bunch of different numbers, and popped them into an equation to come out with your estimated GFR, which in people works fairly well. People have tried to do this extensively in dogs and cats, and it just doesn't. When you look at the estimates that they have, like the last feline one I saw was an equation like 3 pages long that was still only like borderline accurate. So unfortunately, we don't have a good eGFR in veterinary medicine. So what are the advantages of these functional biomarkers? Well, as we said, they give us a good idea of how much function the kidneys have and how much they've lost. This is useful to help us categorize the expected disease burden. This is the foundation of our iris staging of kidney disease. It's also helpful for trending the progression of disease. Is our kidney function worsening, improving, staying static? And probably most importantly, they're readily available, cheap, and easy. Very simple. All of us on every blood panel send out creatinines and ureas and maybe SDMAs on a regular basis. What are the limitations? Well, the biggest one is this top one. They don't change until enough damage has been done to affect kidney function. This means that we need about a 2/3 to 3/4 loss of our kidneys to start elevating our urea, creatinine, and SDMA, which if we're looking for an early marker, oh gosh, 75% of the function lost is not exactly early. They're also a static marker. They don't tell me if damage is ongoing or if the current value is a steady state. I mean, yes, we can trend them, but it would be nice to be able to do one test and know, is this animal's kidney function going up, going down, or staying where we are? As we've said, they can't detect early stages of disease, and they're also interfered with by pre- and post-renal causes. A creatinine from a dehydrated animal, and a creatinine from an obstructed animal, and a creatinine from an animal with true kidney disease look exactly the same and can't tell me what the source is. So let's talk about these a little bit more specifically. The first one is going to be our urine-specific gravity. This is a really easy test of just how concentrated the urine is. It's a ratio of a density of urine to the density of water. Loss of kidney function obviously decreases concentrating ability. A decrease in specific gravity is an earlier marker of CKD than elevated blood values are. And so it's one of the first things that we'll see change. It is, however, affected by hydration status, the presence of IV fluids, and by a lot of endocrine and other diseases, especially things like diabetes and hyperthyroidism. So while it's a fairly sensitive test for CKD, at least relative to some of our others, it is very non-specific and unfortunately not really useful for staging or progression. We can't sit there and say, the USG went from 1020 to 1012, so your kidneys are getting worse. It just doesn't really work. Creatinine. Creatinine is, of course, the big one. This is the most commonly used marker of kidney function in cats. Creatinine is produced by muscle and so is affected by muscle mass and body size. And this is a really big thing I drill into my students when we're talking about dogs and we think about the difference between a tiny little Chihuahua and a gigantic Mastiff and the fact that the Mastiff is going to have a much higher creatinine than the tiny little Chihuahua. But thankfully, most cats are about the same size, and so they have quite a predictable creatinine. The majority of cats should have a creatinine around 100. My biggest male gigantic cat has a creat that hovers in the low 120s to 130 range, but really not much outside of that. Creatinine is passively filtered by the kidneys with minimal active transport and correlates quite well with the inverse of GFR. And so as your glomerular filtration decreases, your creatinine goes up. Of course, it is affected by hydration and urinary obstruction, but in general, pretty good test. Most importantly, creatinine is very consistent day to day and year to year. When I look at my own cat's creatinine and I trend it yearly, I'm seeing, 100, 102, 105, 98, 101. There should be minimal change in a healthy animal's creatinine. And what this means is that changes within the reference range reflect changes in GFR. If your reference range for creatinine in a cat goes from 60 to 200, and your cat's creatinine goes from 100 to 150, that has been a kidney injury. You don't need it to be outside the reference range. You just need it to be changed from that animal's normal. I'm going to keep harping on this as we go forward because it's so important. Creatinine is cheap. It is readily available. It is on every biochemistry panel, and it does remain the standard used to diagnose and stage CKD. So regardless of anything else we talk about here, it all comes back to creatinine. I'm not going to spend a lot of time here, but this is just my demonstration of creatinine being the biggest tool. And yes, we talk about SDMA with a little star beside it and UPCs and everything, but that our big staging of kidney disease is a creatinine-based staging. I'm going to bring up this slide for a minute and kind of go over this. And I know I'm harping a lot on creatinine, but it is such an important marker. This is a human slide that I just stole. But you can see here it's correlated serum creatinine on the y-axis with the GFR on the x. And what you can see is that these are different individuals, and there is a distinct trend here, but there's also a huge range within these. There's a big variability between individuals, but a low variability within an animal. So I've drawn an arbitrary line here and set a creatinine of 2. And that creatinine of 2 for one individual might mean a GFR of 10, and for another individual, it might mean a GFR of 75. It's going to change very little. If I look at this individual year after year, they're always going to be in that area, but there's going to be a huge individual variation. And this is where that wide reference range comes from and why we really need to trend creatinine with the individual. Hopefully that makes sense. This is another thing I want to make sure we understand creatinine is that it is a logarithmic and not a linear scale. And so I've just picked some points here and just kind of referencing the line. If I take an animal with a creatinine of 1, that, according to this line, translates to a GFR of 90, 95-ish. If I move them from 1 to 1.5, that creatinine has now gone from 95 all the way down to 45. So a little change in creatinine represented a huge drop in GFR. Now, if I take an animal with a creatinine of, let's say, 5, well, that GFR lined up with, a creatinine of 5, yeah, that GFR lines up with around 10. If I make that creatinine go from 5 to 10, my GFR only dropped a little tiny bit there. And you can see this, that small changes at the low end are more concerning than big changes at the high end. And so this is something where a cat whose creatinine moves up a tiny bit from normal has had a massive change to their GFR. But when it moves from a high to a very high level, that reflects a much less change in kidney function. I know this is a little bit hard to explain, but hopefully that makes sense to you guys. Moving on from creatinine, urea is the next one. Urea has really similar trends and use cases to creatinine. It's produced by the liver from protein and ammonia rather than by the muscle, and it's affected by more factors than creatinine. Rather than just things like hydration or obstruction, urea is also affected by liver function, diet, GI bleeding. It's just a less good creatinine most of the time. The only exception to that is it is our standard measure when we're doing dialysis because it's osmotically active. And so when we think about dialyzing patients, we'll think about urea reductions. Outside of a dialysis setting, usually it's less useful than creatinine, and creatinine is going to be our big marker. That's why you don't see urea in iris staging. And the last big one we're going to talk about in our functional markers is SDMA. This is relatively novel. Gosh, it's approaching 10 years old now, but it is a molecule that's produced by all tissues in the body. It's really similar to creatinine in that it's a passively filtered molecule, but it's not affected by muscle mass. And this lack of effect for muscle mass makes it an earlier marker of kidney injury than creatinine. Importantly, it really isn't an earlier marker if you look at changes within the individual. It's only a little bit of a better marker if you look at changes relative to the reference range. I'm going to bring that up again in the next slide. Another little tidbit, we don't know if this is true in cats, but we definitely know it's true in dogs. Round cell neoplasia, especially lymphoma, elevates SDMA. So if you're seeing an animal who has a normal creatinine, normal urea, normally USG, and their SDMA is like 40 or 50, really start that lymphoma hunt. This is a chart I made last night to try to illustrate this point that is probably going to confuse people more, but hopefully it makes sense. So I've drawn this kind of spectrum with 2 lines on it, and we're going to make that line our reference interval. So this is our arbitrary reference interval for creatinine, and this is our arbitrary reference interval for SDMA. And you can see that because SDMA has less individual variation, the reference interval is narrower. And so if we trend an animal's creatinine year to year, we'll see, a little fluctuation around that value. And the SDMA has a little fluctuation around that value. And then one year, the animal has kidney disease. And we'll see both of them have jumped up by about the same amount. The SDMA is now outside the reference range, but because creatinine has a wider reference range, it's still in the range. And this is why people think of SDMA as an earlier marker. If my sole criteria is, did you go outside the reference range? Then yes, the SDMA will elevate first. But if I think about what's this animal's reference range, then creatinine and SDMA will increase at about the same time. Hopefully that made sense. If not, put in some questions and I can cover it again at the end. Moving on from our functional markers, the other way that we can look at things are what we call damage markers. These measure injury to renal tubular, glomerular, or other cells. These are released due to cell injury or death. Rather than marking function, they tell us that there is ongoing injury to renal tissue. They may be most useful in the context of an acute kidney injury rather than a chronic disease, but we're going to chat about those because they're so important and really becoming a more and more commonly used marker. The advantage to these damage markers is that they indicate the presence or degree of active damage. They let us differentiate ongoing injury from a steady state. If these are elevated, the kidneys are currently being hurt. It's not something that is stable. They are worsening. What they are not very reliable is a loss of function. Because we don't really need them to elevate when there's a loss of kidney function, we see these show up really early in the course of disease, as soon as there's any death of cells, not once the kidneys have lost a lot of function. Because there's a lot of different ones that are secreted sometimes from very specific parts of the kidney, it may also let us localize what part of the kidney is being damaged. What are the limitations? Well, because they don't rely on kidney function to elevate, they also don't let us stage or quantify how much damage is being done. They let us say there is damage being done, but not really how much. They often are not sensitive to all types and locations. For example, if you have a marker that's only released from one part of the proximal tubule and you have damage in the distal tubule, it may not show up. And they may be less useful for CKD for acute injury because CKD is less of an active process. It's more of a chronic, slow progression. This is just another diagram that I took of a nephron. And so this shows kind of all of the areas of your nephron and just lists some of the markers. Again, not things I'm going to cover all of, but some of them. And just the idea that different ones are being produced from different areas of the kidney. First one I'm going to talk about is one that's come up pretty significantly in the last year or so, and this is cystatin B. Cystatin B is an intracellular cysteine protease inhibitor. It's produced in a ton of tissues in the body, but is shed into urine when tubular cells die or are injured. And so it is a marker of active kidney injury. As we've mentioned, it's not useful for staging kidney disease, but if we have an elevated cystatin B in the urine, it means that tubular cells in the kidney are dying. We know a few things about cystatin B, but because it's a relatively new marker, less than a year in commercial availability, we don't know a lot about it. And so it's one of these things that has a big kind of coming soon asterisk to it still, even though we do have a fair bit of information. We know that the urine cystatin B is higher in animals with acute kidney injury than in animals with CKD, and higher in animals with CKD than healthy animals. So we do have a bit of a gradient there. We know that it might predict the outcome in AKI. Animals with a higher cystatin may be less likely to survive than those that are lower. And it may let us predict which CKD stats cats are going to progress versus be static. If we have an elevated cystatin, we know there's damage ongoing to the kidneys and makes it more likely that those CKD animals will progress. That's from a fairly recent paper. We know it's elevated after prolonged anesthesia, which tells us that a lot of those animals undergoing dentals or other 6-8 hour anesthesias probably are getting kidney injury. And we know that standard dose meloxicam therapy does not elevate it, lending more credence to the whole meloxicam probably not as bad for the kidneys as we often think. As we've mentioned, it's very recently commercially available, and we do just need a lot more experience in order to decide what the best use cases and interpretation are. So 5 years from now, this talk will have a lot more information on it, I think. Another one that I've worked with quite a bit myself, is KIM1, or the kidney injury molecule 1. This is a transmembrane protein that plays a role in immune function and viral entry. Its actual physiologic role is not important. What's important to us is that it's produced by a specific region of the proximal tubule, and it is upregulated and shed into the urine after proximal tubular injury. It is a very sensitive and specific marker of AKI in cats and humans. It shows up extremely early after kidney injury, and its elevation in the urine really tells us that there is kidney injury happen. It really does not seem to be altered in CKD. It is quite specific for acute kidney injury. Not a useful CKD test, but may help us to differentiate those animals who have CKD that's become end stage versus animals with a CKD and an AKI on top of it. So definitely some utility there. There is a point of care linear flow assay for it, similar to like a witness test or things like that. It's not commercially available yet, but it is developed and validated, something that we could definitely get to you guys if there was a need for things. There are a lot of other damage markers. Neutrophil gelatinase associated lipocalin, or NGAL, is probably the one with the most research on it, but liver type fatty acid binding protein, vascular endothelial growth factor, heat shock protein 72, clusterin, something called coxin, which is only found in feline urine. There's a lot of these that have had research into them, and they all have very similar roles in terms of upregulated in the urine or sometimes the blood when there's been acute kidney injury. I haven't spent as much time on them because they aren't as validated or commercially available, but they are things that you will see if you start diving into this literature, especially NGAL, that has a lot of research into it. What about other biomarkers that are not associated with function and are not associated with active damage? Well, we do have some of those as well. Proteinuria is a biomarker of kidney disease. Proteinuria indicates the reduced capacity of the renal tubules to absorb protein. It's a marker of tubular damage. Could also be a marker of glomerular damage, but because protein loss in the kidneys is usually tubular in cats, it's a lower magnitude and less of a glomerular marker in this species. We measure it as a urine protein creatinine ratio. We shouldn't really be making decisions based on just a dipstick protein like you're seeing here. It's something that we should be looking at a UPCR for. And we know that a UPCR less than 0.2 is normal, 0.2 to 0.4 is borderline, and more than 0.4 is proteinuria in cats. We know a few things about proteinuria as a biomarker. We know that cats with CKD who are proteinuric have a higher risk of death every year than cats who are not. And that's a big part of why we try to manage this, to try to hopefully reduce that risk of death. But it is definitely a marker of progression and death in cats with kidney disease. We also have some recent data showing that borderline proteinuria in non-azotemic cats is predictive of the development of CKD. So if we have an animal where people are saying, I'm really worried about kidney disease, the litter mate or my other cat died of kidney disease, I know there's no changes, but I want to look at things. A non-azotemic animal with the UPCR of 0.3 or 0.4 is more likely to become azotemic than one with a UPCR of 0.1. There's kind of interesting tidbit there. Some companies really like to hype microalbuminuria testing. It's not useful or superior to UPCR. There's just less data on it, there's less understanding, and there's nothing to support that it's better than a UPCR. So I would really eliminate microalbuminuria testing most of the time from my repertoire and just focus on the UPCR, which is so much better understood. One thing to note is that proteinuria can be markedly increased in acute kidney injury due to massive cell death and inflammation. And so I try not to read too much into it in the context of an AKI. That animal who's in hospital with a pyelonephritis or an obstruction or a toxicity, not really useful there because I've sometimes seen them at 15, 20, 25 in the first couple of days, and then they'll calm right back down to 0.2 a couple of weeks later. So I tend to reserve measuring it for the more stable condition rather than the acute kidney injury condition. FGF23, or fibroblast growth factor 23, is one of the most interesting markers, I think, of kind of kidney function in cats. FGF23 is a marker of phosphate homeostasis. Increases in FGF23 are drivers of CKD mineral and bone disease and likely the progression of CKD. The role of FGF23 physiologically is to decrease phosphate levels in the blood. And we all know that phosphate is the big problem in kidney disease. Our diets are low phosphate diets. We put them on phosphate binders. We're so focused on getting that phosphorus level low because we know it propagates CKD, makes them feel crappy. It's a bad thing to have high. Well, early on in disease, phosphate will increase, and then counter-regulatory factors like FGF23 will push it back down. And so we will see an elevation in FGF23 before we have an elevation in phosphate. Hopefully that makes sense. And that really is helpful to tell us that this animal probably has a higher phosphate load than they'd like, and we'd like to bring it down, that these animals need phosphate restriction. So FGF23 measurement is indicated in patients with CKD and a normal phosphorus. I don't see much point in measuring it in animals with a high phosphorus, because if their phosphorus is high, we know they have too much phosphorus and need a phosphate binder. We monitor it to determine whether they need phosphate binding and to measure the efficacy of that. Ideally, I would like to see a phosphate binder not just decrease my phosphate, but decrease my FGF23 as well. I realize this isn't something that's going to be done in every azotemic animal, but in your patient who wants to be really on top of things, gold standard therapy, I measure this in my own older cats just to try to see if we're having that early creep up of phosphorus that we want to bring down. There is some data that FGF23 may predict the development and progression of azotemia in healthy geriatric cats. This is less proven and can be a bit debatable, but in my cats who have insurance, and I'm a crazy cat guy, all my cats, my personal cats over 10, get FGF23s run with their blood work just because I want to pick things up as early as I can. One thing is there is significant overlap in FGF23 in healthy cats and cats with CKD, and there is a lot of variability in those cats with CKD. As such, there is a little bit of debate as to how useful this testing in non-azotemic animals is. And also keep in mind it can be affected by anemia, hyperthyroidism, or critical illness, severe systemic disease. So not useful in your animals with multiple concurrent conditions. And really the most evidence-based use is in animals with CKD and a normal phosphorus. But, I do think there's probably some utility as an early biomarker as well. What about other less kind of laboratory biomarkers? Well, one thing we don't traditionally think about as biomarkers, but really are at the end of the day, are imaging biomarkers. These meet the criteria we talked about and are really commonly used. Imaging biomarkers have an inherent degree of subjectivity. All of us can look at x-rays or ultrasounds and come up with different conclusions. And obviously it's harder to put numbers on them. They lack sensitivity and specificity, but they're useful in conjunction with other tests. And often, imaging is the only way we reach a definitive diagnosis. Things like urinary obstructions, especially ureteral obstructions, things like polycystic kidney disease. These are diagnoses that are really difficult to make unless we have imaging, in which case they become really easy a lot of the time. So what are some imaging biomarkers we can look at? Radiography gives us a general idea of the shape and size of the kidneys. It's not great. It's not very sensitive. It's not very specific, but it can give us a little hint of what's going on. Ultrasound has really emerged as one of our big tools for evaluations of the kidneys. We get a really detailed idea of the structure, the shape. Do they look big and swollen and acutely injured? Do they look tiny and shriveled and chronically damaged? It allows us to look at blood flow and say, hey, there's a clot or an infarct or a hypoperfused area. And it can also, as we mentioned, give us a specific diagnosis. This cat has an obstruction. This cat has PKD. This cat has these specific conditions. And then CT scans have a lot of advantages as well. Obviously, they're a lot more invasive and expensive. They give us most of the information ultrasound does in terms of structure, shape, size, and blood flow. But they also allow us to actually measure GFR. It's one of the few things that we can do where we can actually look at contrast uptake into kidneys and measure that GFR. A big limitation to CT, aside from access and cost, is the fact that it generally requires anesthesia, which can be nephrotoxic, and requires the administration of iodinated contrast, which can be nephrotoxic. And so I'm often quite hesitant, and I'm in these situations where I'm saying, gosh, a CT of these kidneys would be really useful to evaluate them, but I don't want to anesthetize and give this animal a nephrotoxin because I'm already worried about kidney function. And so it has some inherent limitations there. This is just a little chart I put together of some of the things that we talked about in terms of the biomarkers, whether they're functional or injury markers, what we're measuring, whether they're commercially available, and their sensitivity and specificity for CKD. I'm not going to go over this whole chart again, but I thought it was just a nice page to kind of summarize most of what we talked about and let you see that context all together. And I think one big takeaway from this is that these are things that should be used in conjunction. We all know that specific gravity and creatinine, urea and creatinine, SDMA, specific gravity and creatinine, these first four are really run together fairly routinely. And, some companies, I think IDEX now is including cystatin B in most, if not all, urinalyses. And so, now we've got this cluster of things coming together when we're looking at our standard biochemistry panel with urinalysis. And this is now starting to give us multiple markers of function as well as injury with various specificities and sensitivities that really let us start putting this picture together. And, then when we start tossing in FGF23s, proteinuria, maybe a KIM1, we start to come up with a panel of markers that I think can really give us a lot more insight into an animal's overall kidney status. And I'm not saying every animal coming through a clinic needs this whole panel run, but I think if we're really trying to look at kidney function, this is probably the way of the future in terms of these panels of multiple markers. So, what are our takeaways from this lecture? There are a lot of biomarkers more than just urea and creatinine in feline chronic kidney disease. Despite this, urea and creatinine do remain the standard measures of renal function. Novel biomarkers can play a big role in the diagnosis and prognostication of kidney disease, and there are specific roles and utilities for many of these. Ultimately, panels of multiple biomarkers probably provide a lot more information than any one specific value does. And ultimately, these markers may also be useful in trending. And this is something where we have even less information. We know urea trends, creatinine trends, even SDMA trends make a big difference, as we chatted about. What we don't know is, trends in FGF23 and trends in cystatin and trends in KIM1. How do these actually translate to patient outcomes? And that's something that I think is something we need a lot more information on. So what's the future of biomarkers? Well, there's still a lot of active research in all of these. We're developing and validating additional markers all the time. Obviously, commercialization of tests and production of these panels of tests for early disease detection and quantification are really important. I think more than anything, increased knowledge of the use cases and interpretation of markers. I have people regularly ask me questions about these animals with, hey, unexpectedly high cystatin Bs, or, levels of SDMA that seem discordant with other things, and how to interpret those. And a lot of the time, the question answer comes down to, I don't know. This test has only existed a short period of time. We don't have a lot of research. And I think as time goes by and we gain experience and data on these, we can start to get a lot more information on how to best use them. And I think that's really the big thing, is understanding what we do with the information gained from these markers. Some are really clear. FGF23, you've got too much phosphorus. Other ones, though, gosh, an elevation in cystatin or KIM1 might tell me that there's ongoing kidney injury, but now what do I do with that information? What other tests do I do? What treatments do I implement? And I think those are the big questions that we're going to have, is where do we go forward from here? I think we finished in robust time there, and so should probably have some time for some questions if anything has come up in the chat.
Yeah, we do have a couple of questions.
Perfect.
Wow. One quick question: what urine analytes are potentially more concerning when seen in the dilute urine of a CKD cat than when seen in the concentrated urine of a healthy cat?
Yeah, I think, the big thing that we're thinking about in that context is obviously protein. And this is why we normalize our protein to creatinine, right? Because the normalization of values to creatinine is how we account for that dilution effect. The idea being that as urine is more dilute, the creatinine is diluting. And honestly, creatinine in urine is a much more specific measure than specific gravity. And so things like, okay, 1+ protein in a cat with a USG of 1060 and 1+ protein in a cat with a USG of 1012 means something very different to me. But that's ultimately why I'm normalizing that to creatinine and looking at a UPCR rather than just a point dipstick protein. Other things like cystatin B levels or KIM1 levels, we have a lot more question about. Does it matter if we normalize cystatin or KIM1 to urine creatinine? I have no idea. And ultimately, this is one of those big things that we need to answer. Does specific gravity affect these things? You know, for some values, maybe, for others, maybe not. And this is where these questions arise is, you know, you'll read one paper that looks at NGAL to creatinine ratios, one that looks at absolute NGAL, one that looks at blood NGAL, one that looks at urine NGAL. And it's hard when you have such kind of small numbers of different papers to put this together and understand, okay, what does this actually mean?
Somebody's requesting that you talk about your personal experience with the utility or lack thereof of the cystatin B.
Yeah, I mean, I honestly have not played with it a ton. Because I'm at a university hospital where we have our own reference lab, my urinalyses that I'm getting here don't have a cystatin B on them. I'm seeing it from referral clinics and from lab work I'm getting elsewhere, and once in a while sending them out. A lot of what I'm getting from it is confusion, because I have a lot of people who are saying, you know, okay, this animal has kidney injury and had an elevated cystatin. I expected that. This animal does not have kidney damage and had a normal cystatin. I expected that. It's the ones where we have normal, apparently, kidney function and an elevation in cystatin where we say, I don't know what to do with this information. I think that there is some evidence that those cats probably have some kidney injury going on. But I think it's a question of then needing to look into it a little bit more and say, hey, did this animal just have an anesthetic event? Did it get an overdose of an NSAID? Was there some explanation for it? And ultimately, when there isn't, I think that raises a lot of questions in terms of how far do we chase this down? Where do we go from there? And I think that's part of the problem, you know, with running tests when we don't know what we're going to do with the answer. And I'm not saying that we shouldn't be measuring these values, but I guess I am saying that this is the problem with me running a test in every healthy animal when I don't know what to do with the result of it, is maybe we shouldn't be running it in every healthy animal if we don't know what to do with the result. Maybe it's going to produce something unexpected, but I think right now we just don't have enough information to know what to do with these discordant things. I think that if I had my cat with kidney disease, that's a chronic CKD animal, it might be worth running it and then looking and saying, oh, it's elevated. I think we're at risk of progression. But then again, well, I don't know. I'm trying my best with all my patients already. It's not something where I'm going to say, oh, this cat's at risk of progression, so I'm going to treat this one better. The ones that are not at risk of progression, I'm not going to treat their CKD. Like, I'm still going to try to treat them to the best of my abilities. So while it gives some information, I think we don't really know at this point what all of that information is going to be. I know that's not a very good answer to what you were asking, but I think ultimately what it comes down to is that, like, I don't know. And I think I need a few more years to come up with a good answer to that question.
Potential research project?
Yeah, I mean, I think there's a lot of room for research here, and I mean, it's happening quite actively. I just think that we're a few years early from knowing how to properly interpret a lot of this.
So in relation to that, if I'm a cat owner, and this has been something since ever since I got into veterinary medicine.
Yeah.
So again, the 75% before they start showing signs. What if I'm a cat owner and as my cat increases in age, when would you start routine testing, and what routine tests would you recommend as part of like a just a yearly exam type of thing, so to maybe put some sort of serial numbers on it?
Yeah, for sure. I mean, I think that most people would agree that as a cat starts to get into that 8 to 10 range is where we're starting to look at kind of routine health screening, which shouldn't include basic CBC biochemistry urinalysis. And, certainly that's going to pick up your cats with, advanced CKD. And I say advanced, it might be stage 2, but stage 2 is still pretty advanced in the scheme of CKD, when we think about the fact that, our iris staging system is this much and the disease is this much. And so, yeah, we might pick them up when they're over here. Picking them up earlier is difficult. And that's where it's kind of these questions of, yeah, maybe if we run not a coxin, a cystatin B and a KIM1 and an NGAL and an FGF23, maybe we'll pick up these guys earlier and know that these animals have had some early detection of CKD. And so, yeah, I mean, in my 12-year-old cat, I'm tossing an FGF23 on there just because I've got it. I might send out that cystatin B, even though I have to pay a little bit more for it to go to IDEX because, I'm an internist. I like to have the information. I've got it all there. So like for my personal cats where I'm, interested and curious and they've got insurance and I just want to have all the information, yeah, I'm tossing on these things. I might run a KIM1 myself too and see where we're sitting. For your average client, it's a lot harder for me to justify all of that because I have a lot less evidence of the utility in all of these. And I think these are things that are coming out and that we're seeing more and more of. But ultimately, for most people, I think that like if you have one takeaway here, it's not run this really fancy test. It's trend the values that we already have really closely. And if you look at your cat and say, hey, it was 8 and its creatinine was 96, and then it was 9 and its creatinine was 100, and then it was 10 and its creatinine was 98, and then when it was 11, its creatinine was 130, and saying, okay, this was a sudden jump in creatinine. That's what I'm concerned about. Looking at the previous and not just looking and saying nothing's highlighted in red, nothing has an H beside it, so everything is normal. Saying, hey, this is a change from this animal's baseline and picking up on that. And I think if people come away with that takeaway, honestly, that's going to go a long way. Probably a lot more than cystatin B and KIM1 and FGF23 are reasonably.
And again, what age do you recommend starting those regular kidney tests?
8, 10, 12. I think it's hard to say. I think it's like asking at what age is a person geriatric? I think there are some 65-year-olds who are healthier than some 40-year-olds and some are sicker than some 80-year-olds. And, I think it can be a little bit hard.
Now you did mention hereditary, genetic. Is there, like if their litter mates are, early CKD or something like that, is that something that, you should keep an eye on with?
I mean, I think it's going to raise my level of concern. Do I know that there is a strong heritable component to CKD? I mean, I don't know. I don't think anyone has a great understanding of the precise genetics of this condition. But I think if you have 2 cats who are litter mates in the same house, eating the same diet, exposed to the same toxins, having the same dental and anesthesia and vaccine plans, all of that kind of stuff, well, their nature and nurture are identical. I guess if one of them got CKD, I'd probably pay closer attention to the other.
Okay, that makes sense. Question, should cats be given wet food with less phosphate in it earlier in life?
Maybe.
Maybe.
Yeah, I mean, I think that's an excellent question, right? And I mean, I don't have the answer to that because no one has the answer to that. Like, what amount of phosphate is the appropriate amount of phosphate, keeping in mind that phosphate and protein are so intrinsically linked, and creating a diet that has a moderate to high protein content and a low phosphate content is really difficult. And like, yes, we can do things like adding aluminum hydroxide and lanthanum and things to try to bind out that phosphate, but then we're getting issues with that as well. Do I want my cat eating aluminum for 15 years? Maybe not. Like, I think that there are concerns that way too. And so ultimately, I think at this point, I have very little data to say that a cat with apparently normal kidney function being restricted in phosphorus is useful. What I can say is that if I had a cat who had apparently normal kidney function and an elevated FGF23, I would restrict their phosphate.
Okay. Okay. The FGF23 IDEX, that test is available from IDEX, right?
I think only IDEX, yes. Don't quote me on that. Definitely IDEX, yes. I don't know if anyone else does.
Okay, awesome, awesome. Okay, this topic is one of those that I know has been the bane of cat lovers and cat veterinarians forever, and I don't see that coming to an end anytime soon. In your opinion, to what extent does the diet that we feed cats affect the development of CKD?
Yeah, that's a hard one. And,
Yeah,
when I take a purely research-based approach, if I go based just on the evidence, there is some data suggesting that cats eating a kibble diet have a higher rate of CKD. And there's also a little bit of data suggesting that cats who eat a kibble diet have a lower rate of CKD. And I think that, it even gets a little bit tricky there because saying kibbled versus canned diet is not a terribly meaningful statement because, there are a lot of different ingredients and qualities and everything of kibbles and canned foods. And, is it better to eat a really good kibble than a really crappy canned food and vice versa? I cannot imagine a situation where being better hydrated is detrimental, I guess is what I come down to, though. Like at the end of the day, what's the harm in giving more moisture and making the animal better hydrated? I don't know if it's causing kidney disease, but I know it's not hurting kidney disease ultimately. Like, I don't think anyone ever said, I'm too high. I mean, obviously you could be overhydrated, but you're not going to get overhydrated from eating canned food is my point. I think that kidney disease in cats is probably an inevitability to some extent. We have a species whose normal life expectancy is like 4 years outside, and we're trying to make them live 15 to 20 years. And I mean, I'm in favor of them living 15 to 20 years, but I think we have to understand that if I am stretching a species out to 4 to 5 times what it expected to live in the wild, eventually something's got to give. And in cats, that something is often the kidneys. So I don't know if canned food would prevent them from getting kidney disease. I don't know if it would reduce the risk. I think it probably does. I don't think it's harmful. I have 7 cats at home and work 14-hour days and have neither the time nor money to feed them all canned food all the time. So, I mean, like, I don't practice what I preach. I try to give them some canned food, but my cats get a lot of kibble because that's the reality of my life. And I guess that's where I come down.
So more research, right? More research.
I think so. And I think the study to do this is going to be virtually impossible, is the problem. Like, I think it would be nice, but what we really need to do is take a bunch of cats from birth, take an identically nutritionally formulated diet, half of which is canned, half of which is kibble, and follow them up for 20 years and see when they get CKD. And I just don't see anyone realistically doing that.
No, and I that would be almost impossible, wouldn't it?
I mean, I guess you could do it in a research colony, like maybe Royal Canin or Hills or someone. But again, to have a decent enough sample size, it's expensive to house whatever 50 research cats for 20 years.
Wow. And by the way, just a reminder, if you do have a question, make sure that you put it in the Q&A feature. I got a couple of people with raised hands, so I think they're just missing some questions here real quick. All right. If you have another question, I'm waiting. I don't see anybody with another question here. Okay.
Someone says CE information again.
CE information. Here we go. Let's talk about CE.
Is this it?
Need a race certificate. Please email webinars@everycat.org. Include your full name, your veterinary license, and the state or province of issue, and I will get those to you within the week. So this recording will also be available on our YouTube channel in a few days. If you want to go back and review, you had some really helpful slides on there that I think people would, that are good reference. not only for veterinary practitioners, but also for cat clients. I think important information there that they can share with their veterinarians to start that conversation. So,
For sure.
all right. Dr. Matt, I appreciate so much you doing this for us. This is one of those times that, as I said, the bane of our existence. And just it's confounded us for so long. But I think back to 25, 30 years ago, what we knew and what we know now. Think mostly through research. I think we're getting better, but we still have a long way to go, correct?
Definitely. I think there's always a lot of information we need to find out. And this is an area that there is a lot of active research going into, but I mean, we're still very early in the scheme of things.
And it is. And thank goodness cat health research is becoming more, it's not all about dogs and horses anymore, thank goodness. So yeah, the QR code that you see on your screen, if you hit that, it'll take you to our donate page. Keep in mind that the research that we fund is funded entirely from our donors and sponsors, so we can only fund what we have the money for. So again, Dr. Cornea, thank you. Welcome to the board of directors again too. I'm very excited for that, and thank you.
Oh, you're very welcome.